Assalamu alaikum. My name is Dr. Syed Ahmed Bukhari and I am Chief Registrar of Orthopedic Surgery. And this lecture is my second lecture from a series of lectures in infections on orthopedic surgery. And this lecture is about septic arthritis. Septic arthritis is an inflammation of synovial membrane with purulent effusion into the joint capsule due to infection. It is also called infectious arthritis, and it is a key consideration in adults presenting with acute monoarticular arthritis. I repeat, monoarticular arthritis in adults. If they present with it, please keep in mind a septic arthritis in your differential diagnosis. And it is a medical emergency. It is an orthopedic surgical emergency and should be treated aggressively. And failure to initiate appropriate antibiotic therapy within first 24 to 48 hours of onset of this septic arthritis can cause subcondylar bone loss and permanent joint dysfunction. And if this septic arthritis persists, it can lead to uh, septicemia and ultimately all sequelae of septicemia, septic shock, multiple organ failure uh, syndromes, and ultimately death. Epidemiology is it is more common in infants and older adults, and the reason is low immunity. The extremes of ages are always immunocompromised. 50% of the patients are less than 3 years of age. Males and females are equally affected. And remember, knee is the most commonly affected joint from septic arthritis. Why is that is still unknown, but it is the most common joint to be involved in septic arthritis. As far as etiology is concerned, the infection which reaches the joint can start anywhere in the body. So, as we have seen in acute osteomyelitis can be hematogenous or it can be exogenous. So, the same way, septic arthritis can be hematogenous from a distant infection which travels through blood and somehow reaches the joint and starts to spread and cause infection in that particular joint. And the second mechanism can be through direct inoculation, like some open wound, any trauma, or even the surgery. Or you see, if you use unsterile needles to give intraarticular injections, it can lead to septic arthritis, and it is quite common in our peripheries where untrained people, and local doctors who somehow learn to give intraarticular injections, most commonly in knee. For osteoarthritis, they give injections in unhygienic and unsterile fashion, and this can cause to it can lead to septic arthritis. Septic arthritis can be caused by bacteria, viruses, fungi, or tuberculosis. So it can be caused through hematogenous spread, direct inoculation, or continuous extension from the adjacent structures. As we can remember, you can see in my first lecture that one of the complications of acute osteomyelitis in young children, in babies, is septic arthritis. The infection spreads from metaphyseal region of the bone through the physis and epiphysis into the uh, joint. That pus which starts from metaphyseal region of long bone, it leaks into the joint cavity and cause septic arthritis, and even may present as septic arthritis even before the patient presents uh, for acute osteomyelitis. You can see uh, where how this infection can occur. There are different routes from which this infection can spread, and who are the people who are at more risk to develop septic arthritis? Aging population, the patients who have developed resistance to antibiotics, and or patients who undergo orthopedic procedures, immunocompromised patients, patients who have chronic diseases like diabetes, leukemia, cancer, hypogammaglobulinemia, cirrhosis, HIV, granulomatous diseases, and IV drug abusers, or patients who have some prosthesis, some total knee replacement or total hip replacements can also have increased risk for septic arthritis. The patients of rheumatoid arthritis and crystal arthropathies, osteoarthritis are also at increased risk for developing septic arthritis. The organisms involved are different for different age groups. The neonates have streptococcus infections more commonly, or gram-negative organisms. The infants have Staphylococcus aureus and H. influenza, and children have Staph aureus and Salmonella. The adolescents have Staphylococcus aureus. Look, Staphylococcus aureus is everywhere, and and Neisseria gonorrhea. Adults have Staphylococcus aureus, Streptococcus, and gram-negative organisms. IV drug abusers, Pseudomonas. Pseudomonas is always common in all IV drug abusers, in all infections, anywhere in the body, you will find Pseudomonas in IV drug abusers. The clinical presentation is a red, swollen, hot, tender joint, most commonly knee joint, and the pain is severe enough to limit the use of that joint with systemic uh, symptoms like fever, malaise, lethargy, and fever is usually high grade fever. In children, you will find patients, bache, babies who are irritable, they refuse to feed, they are warm, and there is some localized warmth, tender, red, swollen joint, and patients are usually septicemic. Investigations, the first investigations would be CBC, and you will have increased total leukocyte count, neutrophilia, there will be raised ESR, CRP, and blood cultures are always usually positive. And one of the most important investigations in septic arthritis would be joint aspiration. And after joint aspiration, that aspirate should be sent for culture sensitivity and gram staining. And here is a picture, a table which shows changes in joint aspirate in different conditions. Like if there is septic arthritis, what would be the changes in different parameters of joint aspirate evaluation, joint aspirate examination. Uh, the appearance would be purulent pus, the viscosity would be low, the white cell count is very high. it is always very much higher than 50,000 per millimeter cube, and glucose is always low, and the cultures are positive. Obviously it is due to organisms, and you will find cultures, positive cultures for different organisms. In tuberculosis, the appearance is turbid, viscosity is low, and white cell count is less than 2000. White cell count is less than 2000, and glucose is low. And rheumatoid arthritis, the appearance is usually cloudy, the viscosity is low, and white cell count is more than 2000, and glucose will be normal, it will be equal to plasma, and there is no bacteria, and as always, just like in CSF, in tuberculous meningitis, glucose will be low. In bacterial meningitis, glucose will be low. But in viral meningitis, glucose will be normal. So that's similar in septic arthritis as well. In gouty arthritis, the appearance would be cloudy, viscosity will be normal, and vital count will be 2000. Same would be for pseudo gout, and the only difference between gout and pseudo gout would be the change in crystals. And in gout, there will be urate crystals, and in which would be normally bifringent, and in pseudo gout there will be pyrophosphate crystals. Osteoarthritis, there is appearance of clear yellow fluid with high viscosity, less than 2000 white cell count, and crystals may be present, maybe not. In radiography, in early stages, the joint may look normal, except widening of some joint space and mm, some expansion of joint capsule. So in this stage, ultrasound is more sensitive than X-ray, and if that infection has started to cause damage within the joint, you will see some changes in radiography. There will be narrowing and irregularity of joint space, and you may have osteomyelitic changes in adjacent bones. The MRI and radionuclide imaging are helpful in diagnosing septic arthritis in obscure sites such as sacroiliitis and sternoclavicular joint. The management of septic arthritis starts even if it is uh, mildly suspected. You suspect septic arthritis, start managing it. Do not wait for its final diagnosis. Blood and synovial fluid samples are taken, and the empirical IV antibiotics are started based on their gram staining. You do not even wait for the culture sensitivity to come. You start with IV antibiotics, IV fluids, IV analgesia, and antipyretics, and you start IV antibiotics, and you send pus for culture sensitivity, and you do joint drainage. Remember, if you have septic arthritis in your hand, always drain the joint. It is very necessary to decompress the joint and drain the pus, uh, because if that pus remains there, it will lead to damage to joint cartilage and joint structures. And after when the culture sensitivity report comes, you can adjust the antibiotics according to their culture, and you can change the antibiotics, and that IV antibiotic should be continued for 2 weeks.